is Dr. Joshua Milner, who's a professor of pediatrics and the director of the Division of Pediatric Allergy, Immunology, and Rheumatology here at Columbia NYP. Dr. Milner is a leader in the discovery and immunopathogenesis of genetic diseases that lead to allergic symptoms. Welcome, Dr. Milner.
Hey, so I've been told to talk fast, so I'm apologizing in advance, but you really don't have to tell me to talk fast. You'll find out. So I wanted to talk about a rare disease, although in the end, I do think it's very important to point out that we really do believe that at least when it comes to immunologic disorders, that rare diseases are just simply on a spectrum, and that the underlying pathological causes of rare diseases simply inform the pathological causes of more common manifestations of disease, and in fact, though, also inform a more of a precision medicine way of approaching the different types of disorders. And the immune system is obviously near and dear to my heart. This can apply to other specialties. It just happens to be that our organ of interest can be usually drawn from a simple blood draw. We don't have to, transplant valves and things like that. It makes it a little bit harder to get to stuff. And so that just lends to the responsibility on our part to actually utilize the fact that we can get in there and look and see if we can get some insight that way. This Venn diagram, because you have to always have a three-part Venn diagram when you talk about anything. And this is really primary immune deficiencies is really what everybody kind of thinks about when you think about a genetic disease of the immune system. That's just because historically there was this very, very severe phenotype that could happen, and it could be fatal if it were not treated. And bone marrow transplant is one of the main ways that those are treated. But over time, it became clear that there are genetic diseases that lead to immune dysregulation. The immune system can't control itself, from autoimmunity, autoinflammation, colitis, and lymphoproliferation, even cancer control. And finally, my particular interest is in primary atopic disorders, where again, a monogenic cause of an allergic phenotype, which may or may not be associated with infection or with autoimmunity. This camera is not on, right? Okay, so okay, fantastic. And these are just different examples where there's overlap and where there's not overlap, and that's the example. But again, when you sort of look at how that continuum might work out, people who have severe responses to flu and COVID and nothing else, there could be a monogenic cause. Lupus and juvenile idiopathic arthritis, isolated autoimmune disease diagnoses, again, there could be a monogenic cause. And then with allergy as well. Just to give you an idea of why we're paying attention here. Evans syndrome, which is an inflammatory cytopenia that can happen in children and adults. When it happens in children, if you just take consecutive children who have Evans syndrome, about 60% of them have an identifiable monogenic cause, right? That basically means that genetics must be a part of the workup of any child who has Evans syndrome, full stop. Interestingly, in adults, the yield is not nearly as high. But again, in kids, it's an incredibly high yield. That's just one disease. And these are just the 60% are because those are the known ones. How many ones are ready to be discovered? So that's why we pay so much attention to immune dysregulation potentially being a monogenic disorder, because also one of the big keys here is that these many of the monogenic causes of immune dysregulation, in this case of Evans syndrome, have precision therapies, not just bone marrow transplant, because that certainly helps, but also JAK inhibitors for JAK gain of function, or abatacept to give TGF, to give CTLA-4 for people who have CTLA-4 haploinsufficiency. These are very specific, very targeted, life-altering treatments that are only going to work if you actually look and find the underlying genetic issue. So this actually was a patient who was seen by Alexis Bonaparte and others around here, a 15-year-old male, July 2020, daily high fevers for 2 weeks with weakness, fatigue, decreased exercise tolerance and evanescent rashes. That's July 2020. So everybody's thinking MISC, right? And so the poor pediatric rheumatologist we had, who were getting absolutely beaten by MISC, came along. Oh, this is something that's mine. This is juvenile idiopathic arthritis. It's not MISC. He was absolutely right. He started the patient on anakinra, which totally got him better, and he's on canakinumab now. But the truth was, it was not a particularly classic presentation of juvenile idiopathic arthritis, in that the child had, or the teenager had several episodes of lymphadenopathy, which were really not a big deal. They were just lymphadenopathy. There was nothing malignant about it, and it wasn't even lymphadenitis. It was just he had swollen lymph nodes a couple of occasions. He did have multiple ear infections when he was younger. They were pretty bad, but he did not have anything significant like recurrent sinus infections or pneumonias or atypical causes of infections or the such. He did have a significant allergy history and multiple food allergies. He'd been on shots for allergies, and he had eczema as a child. His IgE was over 3,000. That's really not a typical presentation of someone with juvenile idiopathic arthritis. Oh, and I'm sorry that it wasn't in there, but he also had Graves' disease, which at age 12 for a boy is not such a typical thing. But on its own, that's just not what would bring someone's attention that there's an immune problem, except that he showed up with 2 weeks at age 15 with a fever. So I asked if we could send sequencing, and at the time, we could get sequencing done because we thought we were going to solve what was the genetic cause of MISC. So we just, let's just throw that in there. And no problem. Oh, sorry, yes, you're right there. Actually, Steve is the one who would really care. But anyway, I don't know how this got paid for. I'll just sit right there. The bottom line is that he actually had this variant in TRAF3, which was not super exciting at the time to the, how I put it, the reviewers of the genetic information, because the only thing that TRAF3 was associated with was susceptibility to herpes simplex encephalitis, which he had nothing resembling that. But this particular mutation was a truncation mutation. There were only 5 of these out of about a couple 100,000 in like the databases. And so that just seemed odd. And so I asked if we could check the parents, and sure enough, neither one of the parents carried that variant. So this is a de novo variant found by clinical sequencing in the patient of unknown significance, because it's a truncation variant. It's not the variant that was associated with herpes simplex encephalitis. And so now we're sort of stuck. But as an immunologist and as a precision immunologist, it has my full attention. So what do? We contacted some PID folks who were involved in finding that TRAF3, and they're like, I'm not really sure how this fits in. Contacted a basic immunology expert, a colleague of mine in Iowa, who's an expert in TRAF3, and she said, there's a group in Cambridge who may have a cohort of patients with TRAF3 mutations and disease unrelated to herpes simplex encephalitis. And so that was exciting. And then just sort of knowing at the biology of what TRAF3 does, first of all, just take the patient's primary cells. There's less TRAF3 in the patient's primary cells by Western in our lab. That was a good piece of information there. And then we did a functional screen for TRAF3 dependent signaling on peripheral blood lymphocytes in my lab. And indeed, when stimulated with anti-CD3 as opposed to with the mitogen PMA, there was a defect, which suggested a problem in T cell signaling. And the point just being that that's sort of essentially telling us, yes, there's definitely a problem in that pathway. Now, can anybody get this kind of workup when this shows up? No, right? There's no CLIA or New York State approved test to get this kind of answer. We had to use networks of topic-related basic and clinical colleagues to get these kinds of answers, and then leverage labs which can perform these kinds of tests. Turned out we had found a new immune disorder, TRAF3 haploinsufficiency. It led to variably penetrant symptoms similar to our patients, but some of the other patients were quite different. They had bronchiectasis and severe lung disease in some cases. But the point is that now we have some diagnostics to look for if there's a TRAF3 mutation, looking for autoinflammation, looking at chest imaging for lung disease, immunoglobulin levels, and vaccine titers, autoantibody screening. This is now an entire suite of things that need to be done for folks with certain presentations if they find mutations in TRAF3. And also, it's something to think about if someone comes and you don't know yet what their mutation is. The other thing, just to point out, is that because of the mechanism that we now understand for how TRAF3 works, there are a number of precision interventions to consider in these patients, and that have been considered in these patients. Our patient taught others that you should consider giving blocking IL-1, that might be underlying part of what's going on. You would never have even thought that given the clinical presentation of a number of the patients who we saw. Right? Okay, another quick case, a 10-year-old girl who went for her orthodontic braces. I'm trying to, given the amount of money I had to dump on that, I don't want to even think about it anymore, but she had like a plain film at her orthodontist, and on the plain film, there was a radiolucency in her jaw, and everybody got all worried about it. She got a CT, and it showed it's that bad, like a hole in her jaw. But actually, those who follow this very carefully looked at this and said, that's cherubism. I said, what's cherubism? I was supposed to be paying attention to that, I'm sure, in med school. Cherubism, cherubism is actually a benign expansile lesions in the jaw due to too much osteoblast activity. It opens up, it's just in the jaw, and it's just between ages 5 and 15 or so. It tends to be self-limiting, but it can make you look like a cherub. Which, if you read the Bible, I guess you wouldn't see it, but you'd know what it is if you saw Renaissance art. This patient did have chronic diarrhea as an infant. She had ear tubes placed when she was younger. She did have several pneumonias. I'm going to put them in quotes because I'm not really sure how many of them really were pneumonias, but she had a normal immunology workup, including vaccine titers. And so really it was just, there's this thing that's there. But she also had some episodes of blistering rash and granuloma annulare, which is not a particularly common thing. Cherubism, to our knowledge, is only caused by one genetic problem, and that's SH3BP2 mutations. Wendy Chung actually saw the patient, sequenced for SH3BP2, nothing was found. But then some sequencing found a de novo variant of unknown significance in a gene called PLC gamma 2, S707F. That was very exciting to me because I study patients with PLC gamma 2 mutations, but I had not seen cherubism. So what did I do? I contacted a collaborator of mine at the NIH who I've done the PLC gamma work, and he said, Josh, in the paper you're writing with me, there's another patient with a different known gain of function mutation in PLC gamma 2 who has cherubism. And I said, thank you for reminding me about that. And then we looked, though, in the various online tools for what this mutation could be. There are no germline mutations reported, but it is a known gain of function mutation that emerges in lymphoma patients treated with BTK inhibition. And so it would imply that this patient now has a germline gain of function mutation in PLC gamma 2. So we took it into our lab and did calcium flux. You don't need to know calcium flux biology very much to know that ain't normal if this is what normal is. Right? Patient has too much calcium flux. Again, can anybody know? There's no CLIA assay for this. Technically speaking, this is just a research test, but that is what's going to give this patient the diagnosis. Okay. And now, we now have a new genetic cause for cherubism, PLC gamma 2 mutations. And also we have a new thing to look for in patients with PLC gamma 2 mutations, because remember, that was just found incidentally in that patient. She went on to have some facial dysmorphism from the expansile lesions, but at the time, nothing had been noticed. So PLC gamma, we call plaid, because that's what people do, is make a word out of the gene and the symptoms, and then it's as opposed to like Milner syndrome, which is you're supposed to be dead if that's the case. You don't name after someone's name. So that's what we call plaid, mutation of PLC gamma 2. And so again, there's some disease-specific diagnostics now that are relevant if you find a mutation or if you find a certain presentation. And there are potential pathway-specific treatments, BTK inhibition, calcineurin inhibition. These are things to now think about for cherubism, which would be interesting, or in certain endotypes. Okay, so the bottom line is that rare diseases and associated sequencing data mutations are recognized in incredibly increasing rates at this point in time. And there's absolutely no way that a single clinician or researcher can ever have enough expertise to cover what comes into referral centers for any specific specialty, and then actually put together what that variant means in terms of what to do for that patient. And the other problem is that when we do a research-based discovery and validation of variants, it takes a long time. This really can take a long time, but the patient's right there. The patient's jaw is expanding right in front of us, right? We need to be able to do something, and we're potentially sitting on information that could be helpful. What can we do about this? So there is a consortium of people who deal with primary immune disorders in New York, started by Jordan and others, and Emily, that has been around for just a few years now. And through that consortium, we've made a lot of collaborative work in the city to do exactly this kind of thing with unknowns that come through. My main partner for this right now is Dusan, who's right there. And Dusan, well, he's really at Mount Sinai right now, but not for long. He's coming here, which is very exciting. And we should applaud that at the end, but we don't have time. So, but the bottom line is that along with Dusan, we've actually created the New York Royal, which is, he made an acronym. I really don't get it, but the point of the regional cooperativity and a unified portal for inclusion of these rare immune, or even just, I don't know what to do. I found a mutation, or I found a patient. What do I do? I'm an expert in 5% or 50%. It doesn't really matter, of things that are relevant to immunity. This is a way of pulling everyone together in a city that has otherwise been rather balkanized when it came to care for immune and genetic disorders. And here, the only way to do this is by crowdsourcing everybody who knows something together, and systemize these referrals and systemize the research-based workup of what to do when you encounter an interesting patient, an interesting lab value, and certainly an interesting variant of unknown significance. So we actually now have a web portal on a Columbia website. It's a very simple form that you fill out with the mutations that are de-identified. And then we've actually formed a standing committee of individuals who, with expertise in a variety of different areas, in genetics, in human immunology, basic immunology, rheumatology, adult and medicine, and computational biology, to systematically go through sequencing and resequencing if necessary. And then through our network of colleagues who work on individual genes and functional assays on individual genes, either within our labs or other labs throughout actually the country and throughout the world, we're able to rapidly get these mutations into the hands of people who know what to do with it, and say, there's a patient waiting for your answer, please send the thing back. Hopefully we'll be able to send them cash. That's going to be for the next grant, although this one is now funded by the NIAID as a resource to work up variants of unknown significance. There are other consortia that do something a little bit like this. There's something called NICER, which is, I guess it's made in the Midwest, so that's why they're calling it that. But it's an immunohematology consortium, again, recognizing no individual place or person can possibly cover all of this. So New York Royal, again, it's moving research-based assays into the clinic. But it's also just moving an integration of the science and of the genetics into patient care in real time, as opposed to waiting for a paper to come out 4 years after the patient has already had the terrible event that could have been prevented if you really had been able to act at that particular point in time. So I just would point out that the advocacy piece of this is important, because this is a very big deal, what's happening right now in the FDA with laboratory developed tests. If it gets oversight that becomes too financially onerous, we're going to have a big problem doing most of the immune testing that we do to figure out what's going on with patients from a clinical point of view, so we can actually act on what we find. I would note that in New York State, it's very difficult to do these things already, so we'll be used to that. But nonetheless, those are barriers to being able to do this type of a resource. But it is something we're nonetheless doing right now. We're working with the pathology and NYP to develop precision immune diagnostics to be able to say, yes, there is a problem in this pathway. This is the type of patient that needs to be treated in XYZ way, and this mutation is meaningful. We then want to get all this information to ClinGen. These are the people who decide, oh yeah, that variant is pathogenic. You don't have to go through this anymore. You just find the variant, we'll reclassify it. We're giving it to them the information in real time to make sure that that happens as well. These are the folks to thank, and the funders. Also, the Jeffrey Modell Foundation is going to be a part of this from the clinical side as well. Thank you all. And it's just an example of how to solve those problems in real time and get funded for it while you're at it.